Hello, everyone. Good afternoon. I want to welcome you to today's webinar. We're going to be talking about using screening, brief intervention, and referral to treatment in your practice. It's also known as SBIRT. My name is Misty Story, and I'm the Director of Training and Professional Development for NADAC, the Association for Addiction Professionals. And I am so honored to be on the first webinar for the New Hampshire Alcohol and Drug Abuse Counselors Association. So I want to give a special thank you to Kim Hyslop and Diane Pepin for allowing me to have the opportunity and for working with NADAC in this way. So thank you very much, and thank you all for joining us today. I'm really excited about today's webinar, and we've got a lot we're going to cover. So I don't want to mince any words and just start right off the bat and get to the meat of it. So what are we going to learn today? We're going to be talking about screening clients for unhealthy alcohol use with SBIRT and using the AUDIT-C and the audit as our screening tool. You're going to learn how to deliver effective brief counseling informed by motivational interviewing, and then also how to link clients to medical or specialty addiction treatment services, and then finally to provide those follow-up and recovery supports that's so helpful to clients to maintain productive lives. I do want you to know right from the outset that this is a 1-hour presentation that was pulled from a much larger collaboration curriculum that came from all the organizations that are on your screen now. And so I'm going to be giving you a snapshot and trying my best to give you as many workable tools in the next hour as possible, but there is a lot more to learn about this topic. And so there's going to be references to this training curriculum that is available through NADAC that is as a home study course, and we do live face-to-face trainings on it if you want to have more information. But again, I'm going to try to give you as many of those scripts and possible things to say and ways to effectively use SBIRT in your practice immediately after this webinar. But if you want more information, there's another way to get it. We'll talk more about that at the very end. I don't want to take up your time now. So good, getting right to the meat of it. Let's just talk about SBIRT and why it applies to addiction professionals. Well, as we all know, the therapeutic setting is a really great place to establish education and prevention and do a behavioral brief intervention program right there in your office that can impact one of the top 3 avoidable killers of America today. As we know, that's unhealthy and dependent alcohol use. And I want to take a pause right here on the very first bullet to point out something that's going to be important for the rest of our conversation. SBIRT's not just about dependent alcohol use. It's actually more geared towards the unhealthy alcohol use in addition to dependent alcohol use. As we'll talk later, there's a lot of screeners out there that really focus on dependent use, but there's a good chunk of the population that really need assistance with their unhealthy alcohol use. We'll talk about what that looks like, but specifically, it means that they're at increased risk of having physical or emotional health problems, or disease or injury. Maybe they've got some work problems or family and social problems. And doing SBIRT can help them to reduce the impact that their alcohol is having on all of these different elements. So again, it's not just for dependence. We're looking for unhealthy alcohol use as well in all those ways I just outlined. And it is currently being used in lots of different places, such as outpatient medical clinics and hospitals, emergency departments, trauma centers, just to name a few. But we are seeing increasingly that addiction treatment and prevention settings are building SBIRT into the practice. And it is being expected that all clinicians be able to be skilled at SBIRT and use it in their practice. The good thing about addiction professionals using SBIRT, as you probably are already thinking, is that you already know how to do most of this stuff, and you're probably utilizing many of the same points of SBIRT protocol in your practice now, so it's not going to change too much of your workflow, and I'm going to try to build on those skills that you currently possess. We also know from research that it can be super effective and efficient method within the total delivery system of the addiction prevention and treatment model. We also understand that sometimes some patients come in already knowing what their drug of choice is, and they can identify it, they know what their problems are, and they have some ideas about those associated treatment needs. But then there are other people who need some other assistance with that, and maybe helping to identify what those problems are, and the big thing is to just start asking about it. As addiction professionals, I imagine this is already into your practice, like I said, but there's a way to hone it to make it more effective that's been based on over 20 years of research. So there's also another flip side. Besides just presenting SBIRT to your clients that are directly in front of you, there's another way that addiction professionals can get involved in the SBIRT protocol, and that's more on the back end. So let's say that there's an emergency room that is practicing SBIRT in their hospital, and they need to have a running list of qualified addiction professionals that can be a part of that referral. Remember, SBIRT is screening, brief intervention, referral to treatment. So that RT component is another place that you can come in and create an additional revenue stream for yourself by hooking up with those other organizations or other businesses that are providing the front end of SBIRT. You can come in on the back end and do the referral piece. So let's just take a big view of screening and brief intervention. What does it really mean from the 35,000-foot view, as I like to call it, from an airplane? So again, brief intervention, screening, referral to treatment, and follow-up. Those are the components that make up SBIRT. And what does that mean breaking it down? So screening, as you know, is just the process of assessing risk. And for this particular protocol, we're going to use a valid, brief 5-minute or less standardized questionnaire that's going to talk about the quantity, the frequency, and the consequences of alcohol use. It can be administered via paper and pencil, or you can just ask those questions verbally, or you can have your clients do them through computer. And it can also be delivered face-to-face or by telephone. So it's really flexible. And then for brief interventions, is a behavior change strategy focused on helping your client to reduce or stop unhealthy drinking. Again, you're not going to get into many minutes about a brief intervention. It can take as little as 30 seconds, or you can extend it up to several sessions depending on what your work capacity allows for. But we can fit it into as much as just 5-minute intervention where you do the screening, brief intervention, referral to treatment all together, very short and efficient. And then finally, that piece about referral to treatment, that's where you guys come in, and I'm sure you know all about referral. It means just connecting your client to a physician for medical treatment or a specialty addiction treatment program. That may be you. You may already be able to provide that medical treatment or your specialty addiction treatment you're qualified to provide within your scope of practice, but sometimes they're going to be presenting with issues that might be a bit outside of your scope of practice, so we'll want to refer those out. And then that key piece that often gets missed, which is the follow-up, and that's the care management, as well as supporting your client during the treatment and the post-treatment follow-up contacts. We'll talk about that a little bit more later on, but I just wanted to give you an overview of where we're going. As I said before, SBIRT is simple and it's brief, it's effective. It's had over 360 controlled clinical trials over the past 20 years that it's been in practice. For some reason, it's just creating a new resurgence now within everyone's practices, and this is being expanded way beyond addiction professionals and medical treatment providers and mental health clinics. It's going everywhere, and so it's super important that you understand how SBIRT works and where it can fit best into your practice. Again, just this might be a refresher on some of your skills that you currently have, but for others it might help just fill some gaps and teach some of those new skills. So I just encourage you to be open to the experience and try to figure out where it best fits into your practice. But regardless of where your skills are, the very first step that has to happen with everyone, regardless of their skills, is to ask. We have to start the conversation about alcohol use in order for this to be effective. And surprisingly, many professionals don't ask that question. They take them at their face value or use just a different method of gaining that information in an intake form and don't go as far as doing a brief intervention, especially not a referral or a follow-up. So there's a few missing components we want to gather together. And you might be thinking out there that this is extra work for your practice and you want to try to get paid for it. So here's just a little snapshot as of the time this presentation was created, that there are approved billing codes for SBIRT, and you can see them on your screen now, depending on the length of time that you spend and what level of intervention that you provide. There are accepted medical codes by the American Medical Association. So that's another way of providing some revenue stream for your practice. So here's some facts. More than half of the U.S. population over age 12 drinks alcohol. And so we understand that the majority of Americans who drink do so without negative consequences. So we've got a huge portion that is able to drink and don't have negative consequences. And then we also have a very huge portion that do not drink at all. And as you know, for some of these people, alcohol leads to physical, emotional, legal, financial, family, or work problems. And that's exactly what we're trying to pinpoint with this SBIRT project. And that leads me to this chart. So out of the people that do drink, here's a breakdown of where they fall on the risk category. You can see the very bottom here, 40%, that's the 40% that represents people who do not drink at all. Then we have a 35% of people that are at low risk of developing problems due to their alcohol intake. Then 20% of the population is at moderate risk, and then there's 5% that's extremely high risk, and that's more of the dependent area that we're most used to working with. So you might be asking yourself, well, where do these numbers come from? What's that really based on? So for the purpose of this presentation, as well as the entire curriculum that was developed by NADAC and our partners, we use the recommended low-risk drinking guidelines, and that's on the right of your slide there. So let's talk about what that's going to look like. And for this, I'm going to reintroduce it many times throughout the presentation, but this is probably the most important thing that you can take away from the presentation today, to talk to your clients about what healthy drinking really looks like. So here are the standards. For men that are under the age of 65, they recommend no more than 2 drinks per day, 14 drinks per week, and 5 drinks per occasion. And so you can see there's a 2-14-5. That's a quick way of remembering 2-14-5 is how much men under the age of 65 should be drinking. Same things for their counterpart for women and also for men over the age of 65. They recommend no more than 1 drink per day, 7 drinks per week, and 4 drinks per occasion. So that's a 1-7-4 rule for women and men over the age of 65. Let's dive a little deeper into that information. When I first read about these drinking guidelines, I kept thinking, it's really strange that you can have no more than 2 drinks per day, but you can also have 5 drinks per occasion for men. That didn't really add up for me. Same thing for women. You can have no more than 1 drink per day, but you can have 4 drinks per occasion. So these things are actually not mutually exclusive. The occasion criteria is there specifically to catch binge drinking. Because if someone's drinking more than 4 drinks or 5 drinks for men in an evening, that would be into the binge drinking category. That's not their typical drinking. That's not how much they drink on an average day, which is where those daily intake rules come from and those weekly intake rules. But when it comes down to the occasion requirements, these are just for your unusual activities and events such as a business dinner party, or perhaps it's a wedding or maybe a football game. And those things happen with any normal drinker. And it doesn't mean that they are an unhealthy drinker if they do step outside of those bounds every now and then. And then just one final reminder is that it's recommended that pregnant women and those under the age of 21 don't drink alcohol at all. So, of course, they would not fit into that daily and weekly occasion requirements because 0 drinking is the healthy drinking amount for those populations. So again, here at the very bottom, you see 40% no risk. And so these are the people who have never had any, who don't have any alcohol. They don't drink actively. And these individuals obviously have no risk of experiencing alcohol-related problems with their health, their work, or their family. That makes a lot of sense. They're not drinking, so they wouldn't have any problems experienced from drinking. So let's move up to the low risk. What does that really mean? It means drinkers who never exceed the recommended daily, weekly, or occasional limits for alcohol consumption. So these people always drink within the recommended guidelines. Whether they're women, men, whatever their age is, 35% of the population is going to fit within low risk. And so we're not as concerned by them because they are drinking at healthy levels. And moving up one more level is that 20% moderate risk. And these people regularly exceed one of the recommended daily, weekly, or occasion limits for alcohol consumption. So that's an interesting population. Keep your eye on them. We'll come back to them in a moment. And then as you might expect, the top 5%, these people regularly exceed 2 or more of the recommended daily, weekly, or occasion limits for alcohol consumption, and they are at extreme risk of developing alcohol dependence at this point. But that's only 5% of the population. Then we have 40% there at no risk whatsoever, so 45% are taken care of in different ways. 35% are not drinking in unhealthy ways, so we're not that concerned by that as well. But what about this 20% of moderate risk people who do frequently exceed one of the recommended daily, weekly, or occasion limits for alcohol consumption? Our current screeners aren't really built to locate these people or identify them in your office. We're more geared towards finding that top 5%, the dependent individuals within our population that's sitting in front of us. That's where SBIRT could be super effective because not only will it identify the top 5%, it's also going to capture that middle ground of moderate risk for 20% of the population. That's a large percent of the people that are going to be sitting in front of you. What we do know also through lots of research is that unhealthy alcohol use can be effectively managed and addressed by you, the addiction profession. But drinking patterns have to be identified. So the biggest problem that we have within the profession at this moment is the failure to ask about unhealthy drinking. And there's lots of opportunities that are built in to do that, where you can ask and then even more so, provide some advice and counseling to help make a huge difference. We know that that brief intervention, even if it's just a few seconds long, has a long-lasting impact. So now we're going to go to our first polling question, do a little interaction here. So if you want to answer this question for me, we'll respond to it live. So the question is, more than half of the U.S. population over 12 drinks alcohol. Is that true or is that false? Go ahead and enter your response now. Okay, great. So we've got 1/4 of the population out there that are tuned in today that are agreeing that it is true. We got a few people thinking that it's false. It is true. More than half of the U.S. population over the age of 12 drinks alcohol. So that's an important fact to remember of how many people are we really talking about that has the potential to have unhealthy drinking. A large percentage of the U.S. population. So moving on, let's just dive right into how are you really going to do screening. As a LPC myself, I fully understand that when you come to webinars, you want to know some technical information to get you hitting the ground running right after the webinar. So let's do that. Let's start with number one. The first step is screening. So what we're going to use for screening is the audit. There's lots of other good screening questionnaires out there, but we really recommend using the audit, and there's some very specific reasons of why that is. Most notably that it is a valid questionnaire. It is very short. It's been created by the World Health Organization and accepted around the world and vetted for many languages and cultures. So it really has a wide net that's going to catch those hazardous and harmful use as well as the alcohol dependence. Like I said before, many other screeners don't look for unhealthy alcohol use, just the alcohol dependence. And we really want to capture that 20% of people that had previously not been helped in this manner. So the audit is just 10 questions, and it relates to quantity and frequency of use, and we're going to ask you about symptoms of dependence and look for those negative consequences of drinking. The good thing about the audit as well is that it can be used with other screening questionnaires, for example, the DAS or the NIAAA single item drug screen, or maybe the ASSIST if that's what you're using for drug and tobacco use. It can also be combined with other mental health screeners such as the Patient Health Questionnaire 9, the PHQ-9, so that'll help you with depression. We fully understand that there's a lot of questions you're going to want to ask your clients and a lot of things you're going to need to know. And so specifically singling out questions regarding alcohol might not be most conducive for your practice, and you might have to combine them with other screeners. And this one has been tested and for validity and absolutely are able to be paired up. So we're going to break down the audit into two different sections. The first is going to be the first three questions, and it's called the AUDIT-C. And that C stands for consumption, because this is going to be the first thing you'll do with clients to screen out any of those people within the healthy drinking section. So that's the 40% that don't drink at all, and then the 35% who drink within healthy levels. So that's going to knock out 75% of the population that you're talking to by simply asking the first three questions of the AUDIT-C. And it generally takes about 1 minute. We're going to be talking about the quantity and frequency of use. And this can be used just by itself or a part of a larger screening set of questions. Or you can also use it on the back end as an objective tool for tracking change. So for example, if you just want to ask these three questions to set a baseline at the beginning of your relationship with a client, you can revisit this throughout your relationship and your sessions with them to see if their drinking habits have changed. So before you even get to the audit, you want to ask one simple question. And it may seem really simple and really elementary, but you want to just ask them, do you sometimes drink beer, wine, or other alcoholic beverages? If they answer no, obviously no further screening is necessary. But if they do answer yes to that, you'll want to go forward with the AUDIT-C and at least ask those first three questions. And just a caveat, we are going to be asking about how many drinks they have per day, for example. And so that may lead to what is a drink? What's a standard drink? You can see them all compared on your screen right now, and this might be helpful information for you to provide to your clients because, as we all know, someone with a big jug from the Big Gulp from QT might think that that full of wine is one glass, whereas obviously it's multiple glasses or perhaps even a bottle, depending on if you're getting the Route 44 Big Gulp. Obviously, I drink entirely too much Coca-Cola to know about that information. So let's move on to what those questions look like. These are the actual questions of the AUDIT-C. The first one is, how often do you have a drink containing alcohol? And you can see there are answer choices there for never, monthly or less, 2 to 4 times per month, 2 to 3 times per week, and 4 or more times per week. And if you see that top column that has 0, 1, 2, 3, 4, those are the corresponding scores that go with each of those answer choices. And so you'll simply just record that score off to the side of that question. Obviously, if you're answering this yourself, or asking these questions yourself, then you would have that score. If you're just giving this sheet out to a client, you would want to exclude that score tally and the numbers that are corresponding to the answers because you wouldn't want to give away that there are different scoring methods. So the second question is, how many drinks containing alcohol do you have on a typical day of drinking? As you can see, those answer choices go from 1 all the way to 10 or more. And then the third question, how often do you have 5, and that's just for men under age 65, or 4 or more drinks on one occasion? So obviously that question would want to be modified depending on the age of the individual sitting in front of you and their gender. So those are the first 3 questions. And what you'll do with that is tally up all the scores for each of those 3 questions and then add them together at the bottom box. If they have a score of 4 or more for men that are under the age of 65, or a score of 3 or more for women or men over the age of 65, that is a positive screen, and you want to continue on with the next 7 questions. So you can see how easily that would get to a score of 4 or a 3. If someone's having a couple of drinks just during a typical day, that's going to be a score of 0 for that question too. But if they say they drink 4 or more times per week, then that's going to give them a score of 4, which automatically bumps them up into the category of needing to continue on with the rest of the screener. That information doesn't go very much beyond that. Just simply, this is information that score tells me, do I need to continue on with the rest of the audit, or can we stop now? So over the score of 4 or 3, you want to continue on with the rest of the audit. And so what are those questions? These first 3 numbers, 4 through 6, are really focused on dependence. And I'm sure you're going to recognize them because they're typical questions on many other screeners, such as how often during the last year have you found that you were not able to stop drinking once you had started? And how often during the last year have you failed to do what was normally expected of you because of your drinking? And how often during the last year have you needed a first drink in the morning to get yourself going after a heavy drinking session? So those are really typical questions that we're used to asking. They really fit on that dependence scale because that's something you do want to know as well. But here are the harmful use questions that I think are really interesting. Number 7, how often during the last year have you had a feeling of guilt or remorse after drinking? How often during the last year have you been unable to remember what happened the night before because of your drinking? Have you or someone else been injured because of your drinking? And then finally, has a relative, a friend, or a doctor or other healthcare worker been concerned about your drinking or suggest you cut down? And so just like with all the other questions that I showed before, there is a scoring sheet at the very top that tells you what each of those answer choices correspond to score-wise. You tally those all up and do an entire score tally for all 10 questions, including the first 3 that were asked as a part of the AUDIT-C. And then you can see now here on your screen, there are thresholds that can let you know what level of risk that score falls into. So for a total score of 0 to 7, that's going to be low risk. For a score of 8 to 19, that's the moderate risk, and we think that those are potential harms. And then a score of 20 or above, with the highest being a 40, that's going to be high risk with possible dependence. So now what do you do with that information? There is one little caveat that I want to give, is that yes, I have given you these thresholds, and there are some fixed thresholds where you should abide by, but at the same time, there's really not a difference between a 10 and an 11 on this moderate risk. The point is that they're in moderate risk, and that there's a couple of red flags letting you know that perhaps this is a conversation that needs to go a little more forward. And so even if they're a 10 or even a 13, that's still moderate risk. And so these are threshold ranges more than they are just hard and fast numbers. And especially if you've got someone at a 19 who's right there at the cusp of having a 20, you want to use your own clinical judgment to decide whether that person needs to have more of an intervention and more of a referral than they would if they were more fixed into the moderate risk category. So that's where your clinical judgment comes in. So we've got another polling question here. Let me switch over to that side and I'll launch that one for us. Okay, this question is: an audit score of 8 or higher indicates at-risk, harmful, or hazardous drinking. What do you guys think? We'll give you just a moment to respond to that. Okay, it looks like that we're all agreed. True, that is true. Everybody is corrected though. We've got a lot of smart brains, so thanks for paying attention. It lets me know that you haven't passed out on me yet or closed me out. So we'll move back to the slides and keep moving forward. Okay, great. So moving on to the second step. Now that you know what their score is, what are we going to do with it? So this is a really important moment for clients because this is a brief intervention as itself is it a behavioral change strategy that is by design short in length based on the word brief and in duration, and it's aimed at helping that person reduce or stop a problematic behavior. So ideally, you want to be saying things that are inciting some sort of thought or possible movement or consideration to break down that ambivalence with that individual and help them understand really the reality of their drinking. Of course, you want to do that in a very non-confrontational manner, and we're going to pull on the skills of CBT or motivational interviewing to help guide that conversation. You really want to incite motivation within that individual to make these changes themselves to reduce their drinking or perhaps stop altogether, but that would be their choice. There's a lot of flexibility when they know their score and a lot of really specific ways that you can discuss that score with an individual. The thing that we do know is that if there is a gap of a few days or a week between that brief intervention and when the scoring happened, that's fine. But as the delay increases, the likelihood of that client to show up and immediately act on those screening questions and the score is kind of lost. And so you really want to try to do the brief intervention as soon as you can after the screening. Again, a couple of days or a week, if that's the way your system is set up, that you don't really get that information filtered to you until the next time you see them, that's still fine, but making sure that that linkage is happening pretty quickly will be most effective. And as I mentioned, we're going to be pulling on skills from motivational interviewing and CBT to utilize the brief intervention effectively. So brief interventions typically include the following. You want to give them some feedback about their audit score. That's going to be the same for everyone. You also want to give them some feedback about how their results compare to national averages. That's going to be for everyone as well. And then depending on their score, you might want to express some concern about the potential effects of their unhealthy drinking. You might provide some advice to cut back. You can explore some of the pros and cons of their use with them. Even develop some action planning, and if you can get there, some commitment to action. So there's a lot of options that you want to do depending on their score. And so let's look at those scores directly. What I think is really great about SBIRT is that it directly correlates back to the populations that we most are concerned about. As you can see, the level of risk, low, moderate, and high, that directly corresponds to those percentages of the population I brought up at the beginning of our presentation. Where if you have someone in the low category, they're most likely not exceeding any of those recommended drinking guidelines. People in the moderate category are exceeding 1 frequently, and then the high category are exceeding 2 or more frequently. And so what you'll want to do with these categories, like I said, for the low category with low or zero risk, you just want to provide feedback about that and inform about safe use. Let them know what that looks like and congratulate them for it. Then for moderate use, you want to step it up a little bit and provide feedback about the risk and compare them to national norms. You want to inform about safe use and advise cutting back. Use some of that MI and CB2 in solution-focused techniques, as well as generate some change statements and provide that follow-up. We'll talk more in depth about how to do that. And then for the high category, high risk, you want to do all the things I just mentioned for moderate, but there's a key one in there that you also want to do, which is consider referral to addiction specialists for more intensive assessment and treatment, if that's appropriate. So just diving directly into how do you provide that feedback, I'm going to do my best to give you some sample scripts or some sample text that you would be able to obviously take in your own words and use with your clients the best way that you feel is appropriate. So for those people that have low risk, you want to say something like, John, your answers to questions about your alcohol use indicate that you have a low risk of developing the medical disease of alcohol dependence. Keep up with these healthy patterns. But then perhaps if they're in the moderate risk, you might say something like, Maria, your score on the audit was a 14 out of 40. This suggests that you're at moderate risk of developing the medical disease of alcohol dependence. Your drinking greatly increases the likelihood that you will have an alcohol-related accident or begin experiencing health or other issues. I'm concerned for you. So again, this is just the feedback portion. We're going to be building a total script with each of these components to provide to the client depending on their score. But this is what you can start out with, the first couple of sentences. And then finally, for those high-risk clients that you want to speak to, perhaps you'll say something like, Edmund, your score on the audit was 33 out of 40. This is very high. The amount that you drink and the symptoms you report place you at a high risk for alcohol-related illness, including the very real medical disease of alcohol dependence. You're probably experiencing some of these problems due to your drinking now, which may already be severe. I'm very concerned for you and recommend that you cut back. So as you can see, that first introduction of the feedback about their score varies based on what their score actually is and the level of concern you're going to express at the beginning. And then the next piece that you can do is talk about what healthy drinking actually looks like. I'm not sure that very many Americans really know what healthy drinking is, and this is a great educational moment for you to incite some change when they realize that they're actually in a different population than they thought. Perhaps they are used to all of their friends around them drinking like they do, and maybe assume that everybody drinks like that and it's not unhealthy. Giving some hard facts about that will be really motivational to that client. So again, we want to revisit the simple rules of 2, 14, 5, or 1, 7, 4, which corresponds to no more than 2 drinks per day, 14 drinks per week, or 5 drinks per occasion for men that are under the age of 65. And then for women and men that are over the age of 65, it's no more than 1 drink per day, 7 drinks per week, and 4 drinks per occasion. So as I mentioned before, the percentages of people that are falling into the low, moderate, and high risk categories are directly corresponding with the amount of times they are exceeding the recommended drinking guidelines. And you can directly talk about that. So what would that look like? You can say something like almost 3 out of 4 adults either do not drink or drink at levels that are not considered unhealthy. Those levels are below 14 drinks per week and less than 5 drinks per occasion for men, and below 7 drinks per week and less than 4 drinks per occasion for women. You are in this healthy, low-risk group. Keep up those healthy patterns. So you still want to explain to those healthy drinkers that are having scores of 0 to 7 what those drinking patterns look like, because you want to reinforce that behavior and continue to let them know that these are the guidelines, and you want to make sure and stay within those guidelines just like you are. Changing it just a little bit for those that are in the moderate group. Nearly 3 out of 4 U.S. adults drink at levels below yours. If you reduce your drinking to 4 or fewer drinks per day and 7 or fewer drinks per week for a woman, your risk of alcohol-related health problems will drop significantly. Would you be willing to consider how to decrease your risk? So what I think is really interesting about this particular scenario is that you're providing an opportunity for them to moderate their use, to bring that down. You're not talking about abstinence at this point because they have some risk of alcohol-related problems. You're talking about what it would take in order to get them within the healthy drinking limits. That's a much more digestible solution for many people who are drinking in higher levels to first swallow and understand that there are some ways to drink healthily, and perhaps that they're not drinking as normally as they thought, because nearly 3 out of 4 U.S. adults drink at levels below yours. That's a really powerful statement for someone to hear who previously thought that they had been drinking healthily. And then finally, for the high risk category, you can say something like, your current use of alcohol is more than 90% of U.S. adults. This pattern is harmful to your health and could be causing problems at work or home. You also might say something like, men who drink more than 14 drinks per week or 5 or more drinks on an occasion put themselves at serious risk of problems. Would you be willing to reconsider how you could reduce your risk? So the next component of what you can add into that script when you're having this brief intervention is again, talking about the alcohol education. You want to make sure that they understand that at some levels, alcohol may even actually be healthy for them. We know that research has shown that alcohol can reduce the risk of hypertension and diabetes, maybe other cardiovascular disorders, but it's super important to continue to reinforce that drinking over the recommended guideline levels drastically increases their likelihood of developing a host of illnesses, injuries, and other problems. So it's a double-edged sword. If you drink in moderation, then it can possibly even be healthy for you. If you drink in excess, then that's going to start some problems for your life in many different arenas. So you want to educate your clients about these risks and help them to make a decision to change. So what would that look like? Someone who has low risk, you can say something like, John, you have a low risk of experiencing problems associated with your drinking. If you continue to stay below the guideline levels, your alcohol use may even be healthy. Congratulations. And then for that moderate risk, you can say something like, fewer than 1 in 5 adults drink as much as you do. The World Health Organization found that drinking at this level is hazardous. Adults who drink this much are at much higher risk of developing alcohol-related problems, as well as having potentially dangerous accidents at work, at home, and on the road. The amount that you drink also puts you at a 1 in 5 chance of developing alcohol dependence. So that's just some basic education directly related to their score. And that could be a really big motivator for change. And then for those people in the high risk category, perhaps you can say something like, Edmund, I'm really concerned that your drinking patterns put you in danger of problems with your job, your family, or your health. You may well be on your way to developing medical disease of alcohol dependence. You can also say something like, roughly 50% of people who share your drinking pattern have or will develop alcohol dependence, which is a very serious and potentially life-threatening disease. Fortunately, many people with your level of alcohol use are able to significantly reduce their risk for alcohol-related accidents and health problems by changing their use pattern or stopping drinking entirely. Would you be willing to discuss how you can reduce your risk? I think it's important to pause at this moment as well to point out that we are asking permission. Anytime that you're involving yourself in a conversation with a client about change, you want to get their buy-in. You want to have their permission to move forward with that line of conversation. And just simply asking them, are they willing to discuss how you could reduce your risk, is a great way to get them to say, yes, I am interested and willing in discussing how I can reduce my risk. They haven't committed to actually reducing it yet. That's further down the line, but at least they're willing to have a conversation, which for SBIRT makes all the difference. The fact that they're having the conversation and you can even bring forward this information and provide this alcohol education is really where the moment the change can happen. And so if it gets to a place where you need to provide some concern and advice, you want to make sure, like I said, to do that in a non-confrontational manner. You want to make sure and express your concerns so you can motivate them to change or rethink their use. And we know that providing some simple advice just to reconsider their drinking patterns or cutting back or just abstaining if it comes to that from alcohol can be really powerful. So I don't want you to miss that opportunity to do it with your clients. And if you do have to bring this up, here's a good way you can go about it, saying something like, have you considered cutting back your drinking? Reducing your alcohol use can reduce your risk of problems, and cutting back could really help you concentrate on the issues that lead you to come in today. I'm concerned that your drinking may make things worse. I think following the recommended drinking guidelines would help make things better. But if you're not ready to change, you might consider doing one of these following things. As you can see from the list on your screen, everyone, that these are the things that I'm sure that you're used to providing to your clients. It's the same sort of concern and advice, such as keeping track of how often and how much you're drinking. Notice how drinking affects you. You can list those pros and cons of changing your drinking or deal with things that may get in the way of changing. Maybe you can ask for support from your doctor or friend or someone else you can trust. It's really helpful to provide these concrete examples of ways that they can immediately start to work on this issue if they feel it's something that they want to change without, again, going to the drastic manner of saying that they can't ever drink again. There are other solutions, and I'm sure that you're recognizing these coming from CBT practices of helping them notice their behaviors and working to change them. Some other ideas you might have is that you can ask them to reduce their drinking by 1 drink per day, or you can suggest setting a limit on the number of drinks that they drink per day, or invite them to count their drinks. Or maybe even just the very small goal, which could be successful, of not driving after drinking. Sometimes you have to build small successes in order to get to the larger goal, and just doing one action will lead to another action, which then will lead to a larger intervention. So the last component here is the referral to treatment and follow-up. And I have frequently joked with my colleagues that I think that SBIRT should be changed to SBIRT-FU, but it doesn't really make any sense because that would be a little offensive. But there is a component to follow up after the referral to treatment that really isn't built into the SBIRT acronym, and I feel it doesn't get as much notoriety as necessary because that is really an important piece of this whole protocol. So let's talk a little bit more about what that looks like. So for those clients whose audit score indicates that you need to move them on to a different level, or maybe they need a different intensity of treatment that you can personally provide in your scope of practice, as you know, referral is absolutely appropriate. But it's super important about how you broach and discuss referral with clients that will contribute to their likelihood of successful treatment. We know that this conversation that you have with the client is going to make all the difference of whether they actually show up for that appointment that you make, or whether they fulfill their responsibilities by calling them themselves or move forward the conversation. If you can have this intervention at this point, you can help them get to that next level of treatment that would be necessary based on their score. A good way to do that would be considering making a 3-way call that involves you and your client in the treatment program, or maybe the provider, just immediately after the client consents to treatment. The purpose of this call would be multiple reasons. You'd first want to just inform the treatment staff and the clinician of the client's substance use. And of course, you'd want to do this in the client's presence on a 3-way call. And those treatment barriers and perhaps some ambivalence if you're picking up on that and it would be appropriate to share. You also want to agree as a group on whether the program or some other treatment option is best. So, a little vetting on behalf of that client, as well as gain support from the program to solve or remove some of those treatment barriers. And then finally, the most important, you want to schedule an appointment if it seems like that referral source is an appropriate next best step for your client. And obviously the client would be involved in that conversation. They would be having automatic buy-in and would feel more comfortable with you being involved in that conversation from the beginning to help guide them to the next step that might be appropriate to help with their drinking, unhealthy drinking. Again, the timing is super important. The same way that if there was a large gap between the screening and the brief intervention, if there's a large gap between the brief intervention and the referral to treatment, no-show rates just climb steeply. So we want to try to have this call to set up the referral to treatment within 3 days of getting your client's consent to move forward. Because research has shown us that after about 14 days, 50% of the clients won't show up for treatment. Just regardless of the motivation they showed in your office or the motivation that they're showing independently, half of those are going to drop off just because 2 weeks have passed between the time you talked about it till the time you're actually going to try to make the appointment. So for everyone's best interest, obviously you wouldn't want to waste your time by having it be that delayed, because it's most likely not going to be effective as well. And then here's that follow-up piece that I think often gets really neglected. There's a couple of ways you can follow up with your clients. And it's really important to just reconnect with those clients after just a couple of weeks or perhaps longer, depending on what their particular presenting issue is in your current relationship with them, just to see if they got what they needed from that referral source. You can also ask about how things are going and to check in to see if any additional services are needed. This is a great time to come in and try to continue the conversation about their score. You can ask them if they've given any thought to it. Ask them if they've had any changes since the time you last spoke. You could even re-administer the AUDIT-C or the full audit to gain a comparison to the baseline that was provided maybe 2 weeks or a month or 2 months prior, depending on when you last did that screener. And so these are called booster and linkage follow-ups. You can also do a recovery management follow-up. And the purpose of both of these follow-ups is, again, to reinforce the action plan that's made. Just by calling and asking, hey, did you make it to that appointment that we set together on August 14th in my office? How was it? And provide a little bit of accountability, a little bit of opportunity for that person to provide some feedback about how it went, or maybe discuss more ambivalence. Perhaps they didn't go, and it would have just been left out and fallen through the cracks had you not called to readdress it with them. And continue to show your concern for that client's health and well-being can really go very far for that client. Someone is looking out for them. Someone's concerned and really wants to try to help with no other reason other than to help them. That can be a big motivator to change, way beyond just the motivation to change that is initiated by having a conversation. Engaging with a client to talk about their unhealthy use and the strategies that they're using to correct that is really, really powerful. So there's a lot of benefits. And also, it helps provide an opportunity to maybe resolve some of those barriers that may be between them and treatment. If they say that, oh, I just couldn't get to that appointment that day because I had to watch my baby, or I wasn't able to get off work. Those are some real considerations and real world barriers that honestly do block people from reaching treatment and reaching the next level of care. And by you hearing about those challenges, you might be able to provide some extra services to reduce some of those barriers and get them to the next level of treatment. Again, it's reinforcing that you are concerned about their well-being and that you're going to try to do the best you can to help them move towards a healthy level of drinking, and that you're in this with them. And like I said, you can also have the opportunity to re-administer the AUDIT-C or any other screening tool just to see if there's any change since the last appointment with your client. Some things that we do know for sure is that controlled research studies have shown us that a brief telephone call just within a few days or week to a client who has received the brief intervention from you about their unhealthy alcohol use will dramatically reduce their alcohol intake, unhealthy drinking practices, alcohol-related negative consequences, and alcohol-related injury frequency. The walk-away point for this slide is saying that we know through research that just having a follow-up conversation, whether they agree to move forward in treatment or not, whether they have made any changes or not, that conversation in and of itself is the important thing to happen. Just like it was for the brief intervention when you were face-to-face after the screener, this is another opportunity for a mini brief intervention to take place through that follow-up phone call, and it can really make all the difference. Finally, I just want to put it all together here. I know I've provided you with a whole lot of information, and I hope that you got some helpful tips to walk away with and start using immediately for this presentation. But again, SBIRT's been around 20, 25 years so far, and it is making its way back into mainstream addiction treatment. And we don't want addiction counselors to be left behind from that. We actually want to be leading the way and helping our clients to address their unhealthy alcohol use and capture that 20% that had previously been unnoticed. And there are many more people that we can help, but this is the first way to use to address this problem. And then finally, I know that I've been talking primarily about alcohol use with SBIRT, but SBIRT actually is used for many different problems, behavioral problems and other addiction-related issues. And so the basic principles that I have conveyed today can be transferred to any other drug or issue that your client might be experiencing. For example, they're using it widely with marijuana use right now or tobacco use. You can utilize this with opioid dependence, or perhaps it's with some other medical related issue that you would want to address with a client. The principles are the same. Let's try to use a screener to understand what is a scientific score that we can use to go forward to decide how much intervention is needed. The brief intervention piece is simply about having a conversation to talk realistically about that score. Talk about what concern you have in regards to that score. What does that score really mean for the individual? How does it compare to other people in the population? And what are some ways of reducing that score if it is in an unhealthy category? Then the last piece is referral to treatment and follow-up. That's really about making sure that that client, once the score has been identified and that client is needing additional services, you make the initiative to move them to that next level of care and move them along the process, and then you will take it on yourself to follow up with them and continue to move them in that process. Again, just having conversations make all the difference, and it starts by asking about their alcohol use, using a valid screener to get you a scientific score and a threshold point, and then having a conversation, moving them to referral to treatment, and then following up with them to show that you care. That's all I got for the time that we have allotted, so I appreciate you very much. Again, I just want to let you know that we have a fuller curriculum. Like I said, it's 6 hours worth of education and a 200-page manual that goes along with this. If you do want to get that education, you are more than welcome to get it from NADAC. You can see the source, their website on your screen right now. We do travel around and do this training in its full capacity face-to-face, and we also will be presenting it at the NADAC annual conference in Atlanta, Georgia, October 11th through the 14th, if you want more information about that. Also, NADAC is involved in several initiatives that are moving SBIRT forward. The organizations that I mentioned at the very beginning of this presentation is called the Big Initiative, and we were all collaborators to come together of various different professions, such as employee assistance professionals, psychiatrists, and addiction professionals all came together to discuss what is the best information that needs to be out there for screening, brief intervention, and referral to treatment. And we spent a year having meetings, working together, redrafting, rewriting to come to this place where we all are teaching the same education about SBIRT together to all of our professionals to try to move it forward and be the forward thinkers for the industry. And so I thank you very much for joining me today and for allowing me to take up 50 minutes of your time. I hope you gained something from it, and feel free to submit some questions through the chat feature there, and we'll make sure and get back to you via email. So thank you again, and I will close it down now. Thank you so much.